the sponsors for this week's webinar, Novartis. So our webinar tonight is about how I treat severe aplastic anemia refractory to immunosuppression and unmet needs in severe aplastic anemia. Our speaker for tonight is Dr. Phillip Scheinberg from the Hospital A Beneficência Portuguesa, São Paulo, Brazil. Dr. Phillip graduated in medicine from University of Amaro, São Paulo, Brazil in 1995. He then undertook residencies in internal medicine at the University of São Paulo between 1996 and 1997, and at the Mount Sinai Medical Center of Florida, USA, between 1997 and 2000. From 2000 to 2001, he worked as a medical chief resident in Mount Sinai Medical Center. Dr. Scheinberg undertook his Hematology-Oncology Fellowship and training at the Hematology Branch, National Heart, Lung, and Blood Institute, the National Institute of Health from 2001 to 2006. He then remained on staff at the Hematology Branch of the NHLBI from 2006 to 2011, where he developed several clinical protocols in bone marrow failure syndromes, as well as conducted laboratory research in bone marrow failure syndromes, bone marrow transplantation, cellular immunity against viral, tumoral, and allogeneic antigens. He is currently head of the Division of Hematology, Hospital A Beneficência Portuguesa, São Paulo, Brazil. Welcome, Dr. Phillip. We're delighted to have you tonight.
Well, thank you. Thank you for that kind introduction. It's a pleasure for me to be here. I'd like to congratulate the organization and SSBMT for putting this webinar on a weekly basis and having invited guest speakers to interact and engage with the Saudi medical audience, which has been virtual. And hopefully one day this will allow us to start traveling again and visiting people and interacting with local physicians all over the world. I've had the opportunity to travel to several countries in the Middle East and in Europe and Asia, and it's been a really interesting experience to be able to not only share the data and some of our experience, but also to interact with local hematologists and transplanters and learn a lot. Actually, we do learn a lot every time we are able to share some of these experiences and interests that we have. So I was asked to talk about aplastic anemia in second-line therapy. So I will be, in the next 20 minutes, giving you an overview of what has happened in terms of development of aplastic anemia and what has been new in this setting. So here are my disclosures. And here is the problem. So we do have an empty bone marrow, which is characterized by a hypocellular marrow replaced by fat on the right. This is in contrast to a normal-looking healthy marrow. Now, this is from the same patient. This is a young boy who's at diagnosis, who was diagnosed with severe aplastic anemia, and this is 6 months after immunosuppressive therapy. So we know that bone marrow function can improve with immunosuppression and can also improve, obviously, with bone marrow transplantation. Remember that aplastic anemia, especially in its severe form, it was a really deadly disease. What does that mean? That most patients died after diagnosis. About 80 to 90% of patients died 1 or 2 years after they were diagnosed, and most patients were young. And patients who had more severe neutropenia were more likely to die. So very deadly disease, usually killed people quickly. And up to the 1960s, there was nothing really that was done for these patients. This obviously changed with transplantation of the bone marrow, immunosuppressive therapy, and supportive care. We know today that aplastic anemia is part of a group of disorders called bone marrow failure syndrome, where the function of the bone marrow declines and the marrow becomes more insufficient. Not too different from kidney failure or heart failure or liver failure, except that this is bone marrow failure. And there are several of disorders that are part of this group of diseases, like aplastic anemia is one of them, MDS or mild dysplastic syndrome, PNH, certain hereditary forms of aplastic anemia like Shwachman-Diamond and dyskeratosis congenita, and Fanconi anemia. And we know that there's some overlap between these entities. For example, we know that 40 to 50% of patients with aplastic anemia have a PNH clone. 40 to 50%, usually small. We know that every patient with PNH or paroxysmal nocturnal hemoglobinuria have varying degrees of marrow failure. We also know that there's a 10 to 15% chance of somebody with aplastic anemia progress to MDS. And we know that there's 20% of patients with MDS or mild dysplastic syndrome that presents with a hypocellular bone marrow. I just saw 2 patients in the last month or so who came to me as aplastic anemia, but as soon as I started to work them up, they had a hypocellular form of MDS. Now, what's happening? Why is the marrow failing in aplastic anemia? Well, it's the immune system. You know, there are a few genetic cases, but they're very, very few. They're in the minority. But most patients, especially when you don't identify a genetic defect, have a dysregulation of the immune system with TNF alpha, interferon gamma, secreted by T cells that destroy hematopoietic progenitor cells, leading to hypocellularity, pancytopenia, and death. There's also lack of regulation with decrease in Tregs and Bregs. So it's a very disturbed and altered immune system, leading to pancytopenia and if not treated, death. How do we treat this today? Well, the paradigm is still based on age. So if you're 40 years and younger, and you do have a family member, a brother or a sister who's a matched, you should go to transplant. If you don't have a matched sibling donor, or you're older than 40, or you do have comorbidities that would preclude transplant, immunosuppressive therapy should be the treatment of choice. How does the immunosuppressive therapy work? Well, it's a polyclonal antibody that is directed against human T cells. So this is human thymus, rich in T cells, that is given to a horse or a rabbit. Then the animal will produce polyclonal antibodies against surface antigens in the human T cell, polyclonal, and this is pharmaceutically prepared and given to the patient at the bedside. And although they are manufactured in a similar way, both cause lymphocytodepletion, except that rapid ATG causes a much more prolonged and profound lymphocyte depletion. You can see that 6 months out, the lymphocyte count has not recovered to pretreatment levels. Now, horse ATG is a rather modest immunosuppressant. You can see that the recovery starts at a week, and the lymphocyte count recovers very quickly. So not a very potent drug. Although they're manufactured in a similar way, there are differences between the two formulations of ATG. I have been involved, and several people have been involved in immunosuppressive trials or non-transplant modalities where ATG cyclosporin was given across the board. And you can see that there's a 60 to 70% response rate with ATG cyclosporin alone, and an improvement in survival over time. Several trials in Europe, Japan, in the United States. And there is a problem here in terms of, a third of patients don't respond to immunosuppression. So although 2/3 of patients respond, there's still a third that don't respond. Question is, why don't they respond? How can you make them respond? How can you increase the overall response rate? So this is an important question. And there are some other limitations that we learned from these trials. One is relapse. A third of patients who respond do relapse, usually not leading to a bad outcome. And the problem of clonal evolution, which is about 10 to 15%. I'm not going to spend time here on the relapse and clonal evolution because these are big topics that requires a dedicated talk, but I'll talk about the lack of responsiveness. Why don't patients respond? Not why isn't it 100%? So the question is, are we not immunosuppressing patients enough? Are still autoreactive T cells surviving our immunosuppressive therapy? Or is it that the bone marrow is so destroyed that even if you take out the immune attack or the immune insult, you're still left with a very sick bone marrow that cannot recover? To this goal, several trials were conducted. I've been involved in several of these trials. We were not involved with GCSF, but there's been 5 prospective randomized trials investigating ATG cyclosporin with or without G-CSF, no improvement in response or survival. We did conduct several immunosuppressive therapies doing a third drug like mycophenolate, rapamycin. That did not work better than ATG cyclosporin alone, and keeping patients for cyclosporin for longer, although we could delay relapse, patients still relapsed over time. We moved on to other approaches by giving more potent lymphocytotoxic therapies like rabbit ATG and alemtuzumab in a prospective randomized trial, and this did not lead to improved outcomes either. Actually, the control arm, which was horse ATG in these trials, performed better than rabbit ATG and alemtuzumab. The overall response rate to horse ATG was about 60 to 70%, as one would expect, but with rabbit or alemtuzumab, only about 30 to 40%. So the trial was designed to show superiority, and not only we did not show that, it was not even the same, it was actually worse. So giving more immunosuppression and giving more potent lymphocytotoxic agents did not seem to improve outcomes. So we really have to move on to other approaches, not by giving more immunosuppression or more potent immunosuppression or adding a third drug, adding a fourth drug. Nothing seemed to improve beyond horse ATG cyclosporin. This is where we decided to completely change course and really pretty much abandon giving more immunosuppression. So what did we do? We focused on the stem cells. So here you have a situation, a theoretical situation where the stem cell numbers are limited because they're being destroyed. So if we do take away the immune attack, can we stimulate the bone marrow compartment? Can we stimulate stem cells? Not easy to do. Many people have given high doses of G-CSF and erythropoietin, all negative, but could the TPOs actually do that? We were somewhat skeptical that this would be the case. The drugs were approved in 2008 by the FDA for ITP, and we started investigating the TPO agonist in 2009 for aplastic anemia, for severe aplastic anemia initially, and second line, and then we brought it to front line. So although we were somewhat skeptical, it did work pretty well. In 2014, our trial led to the approval of the FDA for second line. It was approved in Europe a year later, and then it was brought to front line, which is data that I'm not going to discuss, in combination with horse ATG cyclosporin, which led to a New England Journal publication in 2017 and the FDA approval in 2018. And frontline. So that was Eltrombopag in frontline with ATG cyclosporin. So what's the data in second line, which is the title of my talk? The data started with refractory SAA. So these are the patients who don't respond to immunosuppression, and their mortality historically has been really, really high. You can see by these curves in the 1980s and 90s, if patients did not respond to immunosuppression, they pretty much were dead 2, 3, 4 years out. Now, although that improved over time, basically because of supportive care, transplant protocols, and second rounds of immunosuppression. But this is a very difficult population because they're requiring transfusions, they're pancytopenic, they're being admitted for neutropenic fevers, and the options in 2010 were a second course of immunosuppression, which could be given with about 30 to 40% overall hematologic response rate at 6 months. Androgens, which are very popular around the world, and does have activity. We don't know how well they work. May work in about 30% of patients, but we don't know if that number is correct. We know that for patients with telomeropathy, meaning they have very short telomeres, they work really well. About 80 to 90% respond to androgens. And transplantations obviously were offered in salvage patients, but as you can see here, as you grow older, the survival outcomes are worse. So this is 1 to 10, 11 to 30, 30 to 40, and over 40. So as you grow older, a transplantation is associated with a higher mortality. So this is 2010. And this is where their scenario was when we started investigating Eltrombopag in second line. So what was the idea? Well, the idea was that Eltrombopag would stimulate very progenitor cells. Why do we thought that? Because thrombopoietin is expressed in thrombopoietin receptor is expressed in early progenitor cells. Could we stimulate this cell? So that's the question we wanted to address. We know that we can stimulate these cells in vitro. We know that with the thrombopoietin agonists. We know that in mouse models without thrombopoietin, they do have deficiency of hematopoietic stem cells, and we also know that humans are born with a very rare mutation in the thrombopoietin receptor called amegakaryocytic thrombocytopenia, have thrombocytopenia, but eventually they have marrow failure and they die. So there is a theoretical possibility that we could, by giving TPO or a TPO agonist, stimulate that progenitor cell. The problem is that if you were to measure, and we did that in the laboratory, thrombopoietin in patients with aplastic anemia, the levels are sky high, sky high. This is like giving erythropoietin subcutaneously in patients with MDS with anemia with a very, very high erythropoietin level. It's likely not going to work. So we were hesitant or skeptical that given the very high TPO level, that this was going to work. But we went ahead and did the trial anyways using higher doses. For ITP, Eltrombopag was approved at 50 and 75 milligrams. We went up to 150, trying to overcome the high endogenous level. We stopped at 150 not because of toxicity. It was just because we thought that they were giving a high enough dose. So we started at 50, went up to 75, 100, 125, 150 every 2 weeks. And we stopped at 150 with an endpoint at 3 to 4 months. And this drug actually was very interesting because it resulted in a hematopoietic response rate about 40%. It's an oral outpatient regimen leading to multi-lineage responses, transfusion independence, and it was very well tolerated. The pivotal paper was published in 2012 in the New England Journal. This is a follow-up paper published in 2014, after which the FDA led to the approval in second-line anaplastic anemia. So what's the data? So you can see here that the platelet count in these refractory patients, and some patients were refractory to more than one cycle of immunosuppression. You can see that the platelet count usually around 15, 10,000. You can see that it goes up pretty significantly in the months after initiating therapy. Obviously, these patients are going off transfusions. And the first patient here was a patient who started with me at the NIH. I started as a fellow. He started as a patient. And he was enrolled in all of those trials I showed you. He got cyclophosphamide, he got mycophenolate, he got rapamycin. He was just refractory to everything. He was one of the first patients, and he had a beautiful response to Eltrombopag. And if you look at his hemoglobin up here in blue, I mean, he said he had hemoglobin of 8 or 7.5 or 8, and you can see that his hemoglobin went up to 15 or 16. This is not something we were anticipating, but we were clearly seeing multi-lineage responses in this patient population. And we saw an increase in the leukocytes as well, but they were not as striking, but they occurred at the same time as the other lineages were responding. And you can see some of these pre and post bone marrows, which were hypocellular pre and more cellular post, giving you an indication that you're actually stimulating a very early progenitor compartment and repopulating the bone marrow by this thrombopoietin receptor agonist, Eltrombopag, in this case. Clonal cytogenetic abnormalities was one of our main concerns because you're stimulating the bone marrow. So every time you stimulate the bone marrow, you're worried about stimulating bad cells. Obviously, you want to stimulate good cells. And we saw trisomy 8, monosomy 7, which is what we see in aplastic anemia in patients who actually clonally evolve at a rate that was similar to what we have seen historically in hundreds and thousands of patients treated with ATG cyclosporin alone. We do see about 10 to 15% of patients having these type of abnormalities. So this was not different from what we were expected to see historically. In a follow-up trial, which started at 150 milligrams, published in Blood last year, now this is not 50, 75, 100, 125. This is starting at 150 and given it for 6 months instead of 3. So what happens if you start Eltrombopag in second line at 150? We see about 50% overall response rate at 6 months. So this is what we would have expected. And you can see here that over the 40 patients, 15 responded at 3 and 20 responded at 6. So there's about 5 patients who responded between 3 and 6 months. So it looks like 6 months is more of an ideal duration. And you can see here that of the patients who responded, of the 20 patients who responded, many of them, or the most of them, had a robust response, meaning that they had a really, really good response. And that's important because we know that patients who have a robust response are more likely to discontinue Eltrombopag successfully. So this is important, and stopping the drug is also very important in patients who don't need it anymore. So we were able to define criteria that led to the discontinuation of Eltrombopag in patients who have robust responses. And the more robust the response, the higher likelihood that the patient would be able to discontinue. And we have had several studies in the real world, and this is a real world scenario from Europe where Eltrombopag was given here in 122 refractory patients, and you can see here that the overall response rate is about 50%. They do include a minimal improvement category, which brings this response to 64%. So several studies in the real world showing activity of Eltrombopag in aplastic anemia in second line. Now, we gave this drug thinking that this would stimulate stem cells, and we think that's happening, but we have also seen that there's been a lot of immunomodulatory and regulatory activities that Eltrombopag has in B cells, T cells, dendritic cells, cytokines. It decreases interferon gamma and TNF alpha. It also chelates iron. So it might be that the aggregate of the net effect of Eltrombopag involves several things, and not only just stimulate stem cells. So, in concluding my talk, it is possible and likely, actually, that if stem cells are limiting in patients to respond um, uh, to any form of therapy, it might be that Eltrombopag is shifting this curve to the right and increasing the likelihood of somebody respond to immunosuppression as their stem cell numbers start to increase. Keep in mind that Eltrombopag is an oral drug. It's a chelator backbone. It chelates iron, so it cannot be given with milk or dairy products or yogurt or other antacids because it'll decrease absorption. So it's very important to keep this, and this is the same thing for ITP. It's just that it's important to highlight this because this is something we cannot measure Eltrombopag levels in the blood, so we have to rely on the absorption of the medication. It does not have kidney toxicity, so it can be given with cyclosporin. But it can cause in 10 to 15% of patients increase in liver function tests. So it's important to monitor that. Usually not severe, usually it doesn't go too high. In very few cases, it can go a little bit higher. You may need to stop the drug for a little bit and re-challenge the patient, and they tend to tolerate the drug very well. And East Asian patients, given pharmacokinetic distribution, needs to be given the dose in half. So in 2020, now I showed you the 2010 options. In 2020, so we do have second round of immunosuppression that can be tried. Androgens are still very, very popular. Transplantation has its limitations, but it can be curative in patients who are eligible for this treatment modality. And obviously Eltrombopag, which is where we have most of the data actually, amongst all these pharmacological therapies, not including transplant, which adds to the armamentarium of options in second line. So, a 40% overall hematologic response rate with Eltrombopag in clinical trials and in the real world, and data that I have not shown, but Eltrombopag has been incorporated with ATG cyclosporin in frontline, showing an overall increase in response and complete response rate. And this was shown in the American study at the NIH, which was a non-randomized trial, but also shown in the European RACE trial, which was randomized, that I believe will be presented here at this webinar as well. So in staying within my time, this is our group in Sao Paulo, Brazil. This is my email for anybody who might be interested in reaching out to discuss a case or to share some experiences. I really, really enjoy having the opportunity to interact with physicians all over the world and talking about bone marrow failure cases in patients. We always learn and we always try to help as much as we possibly can in helping patients with these deadly disease. It's still deadly disease if it goes untreated. So very, very important to recognize it and start treating it right away. Well, thank you very much for SSBMT for this opportunity to be part of this wonderful activity that you guys have put together on a weekly basis. Congratulations to the success of the event, and I'm hoping one day to be able to visit you all in person and continue to share some of these experiences. Thank you very much.
Okay, I'm Manar Khalil. I'm a consultant at the Adult Hematology BMT section at King Abdulaziz Medical City in Jeddah. And my talk will focus on unmet needs in severe aplastic anemia. Let me just get my pointer. Okay. So the slides are slow to show up. Okay, so definition of aplastic anemia was initially put forward by Kamita in 1975, which is pancytopenia in the context of a hypocellular marrow in the absence of bone marrow infiltrate or reticulin, and with at least two of the following: hemoglobin less than 100, platelets less than 50, and neutrophils less than 1.5. The Kamita criteria has been updated to classify the severity of the disease according to the degree of pancytopenia. So in severe, we have a bone marrow hypocellularity of less than 25% or 25 to 50 with less than 30% residual hematopoietic cells, plus two of the following: neutrophils less than 500, platelets less than 20, and reticulocytes less than 20. Very severe has neutrophils less than 200. Non-severe lies in the middle when it does not fulfill either of these two criteria. This was shown earlier by Dr. Phillip. So just to mention that patients present to the clinic in the same clinical picture of pancytopenia. But if we see here the green circle under aplastic anemia, other diseases or entities are included: PNH, hypoplastic MDS, and the inherited bone marrow failure syndromes. So it's really very important to be able to differentiate between these entities as it will affect the treatment algorithms. So 70 to 80% of aplastic anemia are idiopathic, and in this category, it's usually immune-mediated, and the rest are due to causes like MDS, as I said, associated with PNH and hypoplastic MDS. So when we have a patient presenting, it's very important to do specialized tests, which include chromosomal breakage tests and next generation sequencing tests to rule out the most common of the inherited bone marrow failure syndromes, which is Fanconi anemia, telomere length studies to rule out dyskeratosis congenita, and flow cytometry to detect CD55 and CD59 negative cells to identify the PNH associated with aplastic anemia. I will not talk about the pathophysiology because it was already mentioned in detail by Dr. Phillip. As I mentioned, we have to differentiate the different causes of aplastic anemia. So genetic mechanisms have a role in the evolution of aplastic anemia. Progressive telomere shortening, which is a common finding with somatic cell aging, is present to a significant degree in aplastic anemia. Approximately 8% of patients with presumed acquired aplastic anemia, they have mutations of the human telomerase, RNA, or reverse transcriptase genes. These mutations may limit marrow stem cell self-renewal and predisposes some patients to marrow failure. Gene array technologies have identified large numbers of upregulated genes important in apoptosis, stress response, immune defense response, and cell death. So this brings me to one of the unmet needs, which like these observations may lead to new targets for therapeutic interventions, which could be considered as an unmet need. The slides are taking a bit longer. So at presentations, it is very important, as I said, to confirm diagnosis and rule out inherited bone marrow failure syndromes. 7 to 8% they test negative for mutations. So we have to identify them for optimum management. This is another unmet need. Specialized tests are not widely available in all centers. It's important to decide on the severity of aplastic anemia according to the criteria which I showed earlier, because clinical outcomes depend on severity, and severity dictates the treatment pathway. At presentation, we also need to assess the medical fitness according to age, ECOG performance status, and comorbidities to assign as to which patients will go to bone marrow transplant and which patients will be assigned to immunosuppressive therapy. Supportive care is important all throughout. And HLA typing should be done upfront in case the patients will need a transplant, or some of the patients will need the transplant sooner or later. So how do we decide which patients will need transplant or immunosuppressive therapy? This is a question. So transplantation replaces the whole lymphohematopoietic system, but at the price of GVHD and graft failure, while immunosuppression attacks or modulates the immune reactive T cells, but with less of cure, more relapses, and clonal evolutions. This shows the EBMT activity in 2018, which is showing an increase in trends in transplant, and this includes also an increase in trend in transplant of aplastic anemia or severe aplastic anemia. So as has been mentioned earlier, sibling-related HLA identical bone marrow transplant is the treatment of choice in severe or very severe aplastic anemia for patients less than the age of 40 with an HLA identical sibling. There is controversy about the upper age limit. Some experts, they go up to 50. So this is the frontline treatment when we have an HLA identical sibling. HLA disparities and the fact that risks with transplant increase with age are reasons why immunosuppressive therapy is preferred for patients who are above the age of 40 or who lack an HLA identical sibling. As mentioned by Dr. Phillip, with increase in age, we have higher incidence of comorbidities like GVHD and graft failure and higher mortality. And this is why, as per EBMT data, age less than 20 would have an overall probability of survival of 86%, and it's much lower for age more than 40. So there are still issues with the HLA identical sibling transplants. Do we really need GVHD in aplastic anemia? Unlike in other malignancies where graft versus leukemia effect is important, it is not the same in aplastic anemia. There are still issues with graft rejections and infertility issues because of the high dose therapy. So how can results be improved further? In patients who do not have an HLA identical sibling donor, a match unrelated donor, if readily available in less than 6 weeks, because in severe aplastic anemia you cannot wait for a long time. So this can be considered as the first line therapy in children and young adults. Alternative transplantation, i.e. haploidentical transplant, platforms with post-transplant cyclophosphamide has shown encouraging results in younger patients, but experience is so far limited only to retrospective studies, small numbers that needs longer-term follow-up. As I mentioned, the unrelated transplants, match unrelated transplant is usually performed in age less than 30 years and within the first year after diagnosis of aplastic anemia. Bone marrow is the preferred source of stem cells, and fludarabines, cyclophosphamide, ATG, and low-dose CBI are the more common conditioning regimens used. As we can see again, in younger age groups, we can have better outcomes, up to 85% of long-term survival, while in those more than 40 years, it's only around 50%. Already the immunosuppressive therapy has been discussed in detail by Dr. Phillip, but has there been any progress over the past 2 decades regarding immunosuppressive therapy? We did see that there is progress, and we can see here over the years. This is in 1980, and this is in the beginning of the 2000s. So what are the indications for immunosuppressive therapy as upfront? Severe or very severe aplastic anemia for age more than 40 years, and for those less than 40 years who don't have a compatible sibling donor, and in non-severe aplastic anemia who are transfusion dependent. The optimal immunosuppressive therapy, as mentioned, is horse ATG with cyclosporin, which shows hematological recovery and transfusion independence in 60 to 70% of cases. This is EBMT data registry in 2009, in 2,400 patients. And I think this was also shown, less than 20 years, the response rates and the long-term survival can even reach 100%, while in the older age group, 40 to 60, it's around 70%, and even less than 60% for those more than 60%. This figure shows that the responses are inferior in very severe aplastic anemia as compared to the severe aplastic anemia. A French experience showed that approximately 2/3 of patients do not have an HLA identical sibling donors. In these patients, the preferred modality of treatment is immunosuppression with horse ATG and cyclosporin. 30 to 40% of the patients are refractory, as mentioned earlier. In Saudi, actually, it is the opposite. 2/3 of the patients do have an HLA matched sibling donors. Horse ATG has been shown to be superior to rapid ATG, but unfortunately, horse ATG is not available worldwide, and this is another unmet need. A meta-analysis of 13 studies have compared them, and it has showed a risk ratio of 1.33, mostly due to lower early mortality. Adding a pan-stimulatory marrow agent of the class of thrombopoietin receptor agonists. Dr. Phillip has covered part of this, but the class is represented by Eltrombopag, romiplastin, and avatrombopag. And as mentioned, both FDA and EMA approved it for salvage, but only the FDA approved the thrombopoietin receptor agonist in the first-line setting. When Eltrombopag was combined with immunosuppressive therapy as upfront therapy, the overall responses were around 90%, and the complete responses were 50%. If we compare this with immunosuppressive therapy without Eltrombopag, the response rate was 65%, and the complete responses are only 10%. Here I will discuss 2 trials. where Eltrombopag has been added as first-line therapy. So what is the rationale of combining thrombopoietin receptor agonists in first line? Because these agonists are expressed, because the thrombopoietin receptors are expressed by hematopoietic stem cells and multipotent bone marrow progenitor cells, as well as maturing megakaryocytes. So refractoriness is due to insufficient immunosuppression or a very deficiency in hematopoietic progenitor. So adding TPO receptor agonist will promote the expansion of hematopoietic progenitors. So the two studies I'm going to mention, one is the NIH, which is a phase 2 open-labeled interventional single-arm sequential cohort studying the Eltrombopag addition to the standard immunosuppression in patients with severe aplastic anemia. It included 92 patients whose age was more than 2 years. There were 3 cohorts with similar numbers. The first cohort, Eltrombopag, was added from day 14 for 6 months. In the second cohort, from day 14 for 3 months. While in the third cohort, Eltrombopag was started from day 1 and for 6 months. The primary endpoints were efficacy and safety, and there was a 5-year follow-up. So this shows the hematological responses were highest in the cohort 3, where the Eltrombopag was added from day 1. And this was compared to historical cohorts with just immunosuppressive therapy without Eltrombopag. So the complete responses were 58% compared to 17% in the historical cohort, while the overall response rate was 94% compared to 66%. With respect to the side effects, they were acceptable. And the clonal evolution was consistent with previous studies with immunosuppressive therapy. The second trial is the RACE trial, which was presented in the latest EBMT. It's a phase 3 trial, which assesses the addition of Eltrombopag in naive severe aplastic anemia patients. It included patients more than 14 years of age, and they were randomized 1-to-1 with almost equal numbers. Arm A was the experimental arm, Eltrombopag plus cyclosporin and horse ATG, and Arm B, same doses of immunosuppression with horse ATG and cyclosporin, and the primary endpoints was hematological complete response at 3 months, and there were a number of secondary endpoints. So the baseline characteristics were similar, only 2 points here. It included patients more than 65%, in almost quarter of the patients were more than 65%. And the control arm had more patients with PNH clones, 58 or almost 60% compared to 45%. Otherwise, the 2 arms were comparable. Regarding outcomes, at 3 months, there was complete response rates in the experimental arm, almost double, 22% compared to around 10%. And overall response rate at 6 months for patients alive, not being transplanted, and without clonal evolution was 76% compared to 50% in the control arm, which was statistically significant. There was a very low rate of clonal evolution, and but there was no overall survival benefit. Both arms were equal. This compares just the NIH data with the RACE trial. So regarding overall response, they are similar 8072. Here they compared it with cohort 1 because in cohort 1 they started the Eltrombopag from day 14, the same as the race trial. They were also similar in terms of partial responses and complete responses, 38 and 33%. I think I'll skip this. So studies outside the US have confirmed the activity of Eltrombopag in severe aplastic anemia, and more recently, alternative thrombopoietin receptor agonists such as romiplastin have been investigated as second line. They have shown activity, but they have not been incorporated into first line, and it's anticipated that it will be. Long-term follow-up and different combinations and doses are needed to better define the role of optimal delivery of thrombopoietin receptor agonists in aplastic anemia in the future. Avatrombopag is another TPO receptor agonist, but it has not been, it's been used in ITP, but it has not been studied in aplastic anemia. There are unmet needs with Eltrombopag. Comparisons of the triple immunosuppressive therapy versus other immunosuppression regimens, standard ones, are based on historical controls. So there are no randomized head-to-head trials in severe aplastic anemia, which directly compare the outcomes of the triple therapy to the other regimens. No clinical trials have directly compared horse ATG or rabbit ATG in the context of Eltrombopag. The role of Eltrombopag for aplastic anemia in children is not well defined, and responses, even if they were robust, do not predict decreased rate of relapses or clonal progression. This is the current algorithm for treatment of severe aplastic anemia in 2020. With this, I'll come to my views on the unmet needs. So in terms of immunosuppression, currently we cannot predict non-responders or those who are more likely to relapse at the time of diagnosis. And we cannot predict who will have clonal evolution. And as I mentioned earlier, availability of horse ATG, it's not widely available worldwide. With regards to bone marrow transplantation, an ideal protocol for aplastic anemia is a more ideal. I mean, there is room for improvement in protocols to improve outcomes. The role of haploidentical transplants has not yet been determined, and relapse after transplant is a big issue, and there are no established standards of care for this category. Novel agents, Eltrombopag, has shown promising results and are very likely that in the near future they will be incorporated in the algorithms of treatment of severe aplastic anemia. There might be issues with costs, and the role of the new novel agents like romiplastin are still under study. Other unmet needs are the role of complement inhibition in severe aplastic anemia with PNH clones, but no hemolysis or thrombosis. These group have worse outcomes with allogeneic transplant. So the role of eculizumab use before and after BMT needs to be determined. There are some special groups, Fanconi anemia, elderly patients, pregnant ladies, and patients with comorbidities like liver failure, renal impairment, and heart failure, who need better treatment strategies. The role of androgens and short telomere length syndromes are also an unmet need. So in conclusion, the first-line treatment in 2021 will still be sibling transplantation for patients age less than 40, but the new standard of care might be horse ATG and cyclosporin with Eltrombopag. Refractory patients age less than 30, a match unrelated donor will be the option, and Eltrombopag will be used in the other settings. Thank you for listening. Okay, so Dr. Phillip, and can you hear me? Yeah.
Yes.
Until we get questions, I have a couple of questions. In transplant for patients, I mean, we have some patients who achieve a full donor chimerism, others achieve a mixed stable chimerism, while others have a progressive mixed chimerism. So what would be your approach in those who have a progressive mixed donor chimerism?
So we usually wait. Over time, the chimerism tends to become more donor. And we have not seen the use of TPO agonists for that reason. What we have seen and what we have used is patients who have not a good graft. They have, let's say, 80-90% donor chimerism, but still cytopenic and low platelet counts, and we have and others have used the TPO agonists, both Eltrombopag and romiplastin in that setting, and have seen actually patients improve after a few weeks. Improve their counts, give it for 2 or 3 months, and then stop. So I've seen that. I've used the TPO agonists in that scenario, not necessarily driven by chimerism, but driven by the graft, how the graft is performing and how it's functioning. I would think that if somebody has a mixed chimerism and you're enhancing hematopoiesis from the donor, that eventually that will have a positive impact on the chimerism as well.
Okay. Thank you for answering. So we have a question from Wafa Izzuddin. Can we use Eltrombopag as first line with cyclosporine in low resource countries, or it must be after immunosuppression?
So, as you showed, Eltrombopag has been used with immunosuppression in frontline and is becoming quickly the standard of care, given the fact that there are 2 trials now showing benefit, one from the NIH and one from the EBMT, showing an increase in the overall and complete response rates. So we're seeing in Brazil, it's approved in frontline in association with immunosuppressive therapy in several countries in Latin America as well. And Asia and in the United States. When I came to Brazil in 2012, we developed a trial in 2014 to see if we could use Eltrombopag with cyclosporin, which is Sandimmune, without ATG in frontline. And we conducted this trial. The trial actually finished accrual April 30th of this year, and we treated over 50 patients. So now we're actually waiting for the results, the data to be cleaned, the data to be analyzed. So we're hoping to publish or report these results next year, which is Eltrombopag and cyclosporin alone without ATG, which I think is what the question is about, right? In low resource countries, because ATG can be a little bit harder, as you mentioned, especially the horse formulation, which is ideal. But we don't know now, giving ATG cyclosporin with rabbit, ATG and Eltrombopag, if that is, it takes away the negative effect of rabbit ATG, and it brings the response rate and survival curves higher when you do add Eltrombopag to rabbit ATG. Those studies are still ongoing, and we don't have the answer to that question. But so this is a very interesting question. I think it's an important question, and we'll know next year what the effect of this combination is.
Okay. What age can we give Eltrombopag?
So the trial at the NIH included age of 2 or higher. So this is how the approval went. And it was given in children as well. Now, when you do a subgroup analysis, as you do mention, it doesn't seem to have as much benefit in pediatric patients as you do in the adults. If you look at the effect of Eltrombopag, it seems to have much more of an effect in the adult population than it does in the pediatric population. Now, keep in mind that kids do well with ATG cyclosporin alone. They do have a response rate overall of about 70 to 80% and a complete response rate of about 30 to 40%. So showing a difference in that scenario with Eltrombopag might be a little bit harder. But having said all that, There are dedicated trials looking at Eltrombopag in pediatric patients with ATG cyclosporin, so we'll have more data. But it can be given in pediatrics as well, although they don't seem to, at least on subgroup analysis, to benefit the children as much.
Okay. Can Eltrombopag, is Eltrombopag indicated in all types of severe aplastic anemia, including Fanconi?
Yeah, so that's an interesting question because obviously the development of Eltrombopag and aplastic anemia was in the immunoaplastic anemia, severe acquired aplastic anemia. And since there's been reports of the effectiveness of Eltrombopag in immune SAA, there are trials, and we've been trying to propose these trials for a number of years now to test the Eltrombopag in hereditary forms of aplastic anemia. So there are trials ongoing. There are anecdotes that it might be effective, but we don't have the results of these dedicated trials yet. It's interesting that Eltrombopag actually might have an activity in DNA damage repair, which is something that is absent in Fanconi anemia. So it'll be interesting to see the activity of Eltrombopag in hereditary forms of aplastic anemia, for which we don't have data yet, but it's being investigated like Fanconi anemia.
Okay. Another question is, can you tell us a bit about the role of transplant in severe aplastic anemia? Do you opt for haplo in young patients with no match-related or unrelated donor?
So so if you look at the haploidentical literature, it's been primarily in the second line and mostly retrospective studies. There's been about no more than 50 or 60 patients in second line who have been given haploidentical transplants as salvage. And if you look at frontline, you're only talking about, in the published literature, of only about 20 patients or 17 patients. I think 17. And that's the group from Hopkins, where you had to go up on the TBI dose to 400 centigrade and give rapid ATG as part of the conditioning. So you're starting, so it's not yet fully understood what's the best or the optimal conditioning for haploidentical. Very few patients treated as upfront, and there's a higher risk of rejection. They had to stop the 200 centigrade. There were like 3 rejections and 2 people died. So I would not give, I don't think anybody's giving haploidentical in frontline. Except when they failed immunosuppressive therapy. I think you might want to look at the haploidentical if somebody does not have a match-related or a match-unrelated 10 out of 10 donor. Remember, the outcomes for match-related and match-unrelated donors, especially 10 out of 10, are really, really good and comparable. Haploidentical, we don't know yet. There is the issue of immune reconstitution and other things. So I would clearly give preference to match-related or match-unrelated. Now, if somebody does not have in the salvage setting and their neutropenia is very severe, I think then considering a haplo makes sense.
Actually, in Saudi Arabia, as I said, 2/3 of the patients, they do have a match sibling donor. Next will be the haplo. In terms of match unrelated donor, we have a bit of a difficulty. So maybe it will be our second line after the match related donor.
Yeah, it's not similar. For example, when you look at countries like China, they don't have match-related donors because of the restriction of 1 child per couple, and
we lost the connection. Dr. Phillip? We lost the connection, but until we get Dr. Phillip back, there is one question. Should we start iron prophylaxis when starting Eltrombopag? What other more side effects with Eltrombopag? Actually, Eltrombopag does help with iron chelation. So still, I mean, there are, we need a longer follow-up, but it has been mentioned that it does help with iron chelation, which is an issue, of course, in severe aplastic anemia because of the repeated transfusions. Dr. Phillip? Any more questions? We're approaching the end of our talk, but we would like to have Dr. Phillip to thank him. Dr. Ahmed Al-Askar, can you hear me? Dr. Al-Askar?
But there's a question for you, Dr. Manar, and that's about the prevalence of...
I think we lost Dr. Phillip.
Yeah, which I think we'll try to get him connected. However, meanwhile, we're at the end of our talk.
Yeah.
Excellent talks. Thank you, Dr. Manar and Dr. Phillip, again, for a nice talk. And I think we will just have to conclude here. We'll send him an email thanking him.
Okay.
So in order not to exceed the time that's allotted.
Okay. So I'd like to thank the audience, and I would like to thank the SSBMT for inviting me. And I would like to thank Novartis for sponsoring this talk. And above all, I would like to thank the speaker so we can send him an email. So I'd like to invite you all to our next week's meeting about how I treat AML incorporating novel agents by Dr. Giovanni Martinelli on Saturday, the 19th of December. Oh, we got Dr. Phillip back.
Sorry, I'm very sorry. My internet just dropped temporarily for a minute or two.
That's fine. We approached the end of our meeting, and we extended our thanks to the audience, to the SSBMT, to Novartis for sponsoring the meeting, and above all to you for joining us today for a great talk. And it was a great webinar. We really thank you.
Thank you. Thank you.
Excellent talks and great discussion. Thank you, both of you.